we're going to look at the trends for maternal and child health indicators. Maternal wellness. Now, this area of maternal and child health deals with antenatal and postnatal services at all the public clinics and public-private partnerships with selected private physicians under the National Health Insurance. And just a note here that the services are free for both the public clinics and the private clinics that are under that services, the antenatal services, postnatal services, and child health services that are registered under the National Health Insurance program. So if the private physicians are registered under NHI, the services to the client is free. Okay, but they must be registered under the National Health Insurance scheme. Now, but for delivery at 32 weeks, the patient is referred to the public clinic with their lab results, so that the public clinic is able to get is able to book them. They are able to get notes that is transferred to maternity ward after every visit in the event that they do deliver. Okay, so delivery for the NHI patients is on the public ward. So you don't go on the private ward and say, okay, I'm an NHI patient. So that is covered under the maternity ward services. Okay, the first one is antenatal care services.
I had a question on that. So you're saying that if you attend a private physician in the community who is under NHI, you live on the general ward, public ward, as opposed to having the Oh, interesting. Okay. So now we have a total cultural shift. They're private doctors who are coming to deliver on the public ward now.
No.
Or you're saying that the nurses do the deliveries, still the midwives and medical students and do those deliveries, the NHI deliveries, all NHI deliveries.
Oh, you're right. I'm glad you said that because it clears up a lot of misnomers. If you are an NHI, you have to be an NHI customer first if we registered with NHI. So you, the patient, have to be registered with NHI first. And you have to be attending NHI assigned doctor.
Right.
Okay, to do your antenatal care. Yes, you can do your antenatal care with them. Okay, but when it's time before delivery, okay, not just before delivery, 32 weeks, okay, you are referred to the public clinic in your area, so they give you ample time. Okay, right. So for delivery, and at that time, once you go in for booking, all of your labs are done, and the public physicians see you, make their assessment, classify you, and well, your antenatal care continues until delivery. When you're in labor, you go to maternity ward, and whomever physician is on call, or if you're low risk, the midwife on duty delivers you, even though you're an NHI patient. Okay.
Right.
So the NHI physician hands you over to the public sector.
Now it's clear.
Care. Right.
Okay. So they take you through most of the pregnancy, and then at 32 weeks, you're formally handed over to to the public system in full. So the private doctors
No. So
did not.
there's a little break in between you and the private doctor because you delivered on maternity ward. Once you discharge, the postnatal nurse from the public sector sees you for the first 10 days.
Okay.
Within that 10 days, though, you can go back to your private
Okay.
physician for postnatal care.
Okay. Good. Okay. Good. So
Right.
it's right.
So it's
Public-private
good. Right. It's a public-private
private
partnership.
partnership. Okay.
Yes.
And now is that working out from your experience?
It's working. It's working out. Some patients, the issue is a lot of private patients who have the NHI. Some of them are unwilling for the nurse to come during the 10 days.
Oh.
Because they are looking at themselves as private.
Oh dear. They should be glad a nurse coming to check on them at home. If you had to pay for that, you know how much that would be.
Exactly. But
wow. So they mean there's a stigma for a public nurse to visit you at your home because you feel for private. No, that's what you're actually saying.
Yeah, that's what
that has to be explored. What is the reason? You know, that's a serious stigma you're talking about, where people don't want the nurse.
It's a status thing.
Do they know enough about the nurse? You know, what she's coming for, and you know, maybe that is the gap where the mother, you know,
I don't think
may not
so.
know enough about the role of the nurse who's coming, the visiting nurse.
Well, you may have a point there, but the postnatal nursing home services is well communicated in the community.
Right.
It's even online. Okay.
Right.
What they do, right? But it just could be a class issue. Some people just, you know,
feel that that's more for the working class mother as opposed to the middle class and upper class mother. Now we have to be frank.
Right.
And we talk about class as a determinant of health, or income and poverty.
Right.
And now there's the attitude you're saying to the to the public service is perceived as being something that they don't really need because they're so comfortable and they don't really need it. That's what they're communicating to you. You know, to the service. Yeah.
Right.
They feel fine, and you know, their baby is a nice baby, and they have everything, which some of them do. I agree. So, you know, but it's still good to have the check. I mean, unless they now take their baby to their private pediatrician, maybe that's what it is.
Well, so, that too, the private pediatricians have been added to the NHI package. So, if once you registered with their pediatricians, you can take your infant to them, and but every patient on maternity ward is given a public appointment, an appointment to the public clinic. Even though you might be an NHI patient, you are given the appointment to go to the public clinic. So it is up to you to make your personal appointment with NHI. Okay. So it is up to the private practice to contact their patients to say, okay, your appointment for postnatal care or for your baby to come in is at a certain date. But maternity ward gives you that public appointment for you and the baby.
Right.
At the government clinic.
Right.
So it's a good thing.
Yes.
In fact, it's double. They're getting double. They're getting they're getting nursing assistants from the public system, and they're getting nursing and physician assistants from the private sector. So
yeah, so we should see our maternal and our mortality rates declining, because they're certainly getting the care. That's the whole point, and it's so good,
It's out there. It's out there. And NHI is doing an excellent job in communicating that these services are available.
Right. And the people are responding because there are hundreds of thousands of Bahamians now registered. So they definitely took up the NHI program. And I was telling the students how high the satisfaction rate is. Like it's way up in the 90s. So thank God, they're doing a good job. I think it's about in the 90s. I think that's what I read somewhere. 90%, approval or satisfaction.
And I just attended a virtual information session with NHI. Apparently now they have electronic medical records. So
Yes.
and that is available to the patient. So similar to the Cleveland Clinic, you can, once you log in to, based on their directions, you can see your lab results,
Excellent.
So they are pushing this public-private partnership, which eases the burden too on the public system.
Right.
And like you say, Dr. Moxie, it helps to reduce the infant and maternal mortality rate.
Yes.
Because the chances of, once people have more contact with healthcare providers, they're more educated. Danger signs are reported sooner. Once you increase that access to help.
Yes, it's true. Access here, that's a critical factor. Yep. Very interesting.
So back to the go ahead. What you saying?
I was saying, I guess some studies should be done, some patient satisfaction studies. That's what, surveys, could be done at some point, to look at how the people feel about it. But that, what you said was so interesting that there's actually some non-acceptance or resistance to a highly qualified, trained midwife, because that's the level of the community visitor, right?
Yes, it's the midwife.
To coming to see you because you are private. Now that one, I really can't fathom that one.
Now, statistically, that happens, less than 50%, less than half of the people.
Yeah.
So, a very small minority of people.
In your role, what? No, but it's something that has to be thrashed out.
It is a reality, yeah.
Yeah, because why?
Well, it could be associated with culture too. Bahamians, we think that private is best, or private makes you look wealthy, even though the neighbor don't know that.
The other thing too is when the nurse, and this could be community-wide for all public health people, there's still that suspicion. Oh, my neighbor can see the nurse coming in the house in the blue.
Exactly.
And what's she going over there for? And they must see got something over there. They must see got TB or something. They, the people immediately
think.
Or what? Or COVID. Yeah, like it's education, because I really don't see much about the community nursing service, like how they promote other health things, like I think public health ministerial has to step up a little bit and promote their services instead of just assuming everybody knows about all these wonderful services. That's the gap I'm seeing. You don't see anything on men's health, adolescent health, even child. Well, I guess everybody knows about child health and maternal health, but some of those less known services are not promoted at all, so that would be my 5 cents on that. It's a information gap where people just don't know what you're coming for, and then that neighborhood stigma, the nurse was coming in, and because there is a stigma with that, where if the nurse is seen visiting you, something must be wrong in your household, and that kind of thing.
That's very important what you just said about the stigma thing, because that was highlighted, especially recently, how we're still in the pandemic, the COVID pandemic, with the postnatal nurses. Initially, we had stopped the face-to-face home visiting during the first and second wave because it was really raging. But as the cases went down, we had recommenced the face-to-face visiting. And in order for us to implement that, you had to almost dress down in hazmat suits. Okay. So
Right.
imagine you coming to your or you seeing a nurse coming to your house or the neighbor's house with a hazmat suit. Now, the hazmat suit is not because you are infected. Okay. It's just for protection of
Right.
the,
Yes.
you
Yes.
know,
The healthcare worker.
right.
Definitely.
So,
Because
right.
you want to deliver the service, but you don't want to get infected by going to a house which may have it and not even know they have it.
Right. So
That's
the
problem is
patient themselves may not have been infected, but the patient don't live by themselves. They live with a
exactly.
host of family members. So,
Right.
you
Yes.
know, so the risks were high.
Definitely. Yep. It can happen just like that.
Right. So that stigma too of
In
this
someone coming, right.
PPE. Mhm. And without the COVID, the pandemic, people uniform. Like you said, you know, people when they see a nurse going in, you know,
Right. There's a connection with HIV AIDS too, I think.
right.
And tuberculosis and yeah, the infectious diseases, I think,
Mhm.
some in the back of people's minds, they associate those two. No, seriously, I think that's
Right.
the DOTS program or the I don't know, contact tracing. People may have some knowledge about it and try
Yeah.
to put two and two together,
But
incorrectly.
once they know the mother was pregnant, then they put two and two together and say, well, okay, that's the nurse coming in to check.
Right. Yeah, that's true. Yeah. Close in the community, everybody would know who just had a baby. That's true. That's the good side about it. Yeah.
But red
May not,
flags
it
go
may
up
not be
once
as
they
negative as
see
I'm saying.
red flags go up once they see the PPEs. So yeah, that
Right.
right now in the pandemic, it's a little strange. So
Yeah. Yeah.
we're still working on that, but we appreciate and we'll take note of your point, Dr. Moxie, with the public service announcements and getting
Right.
that information out there.
Definitely.
Right.
So students, you have any questions so far? Sorry, we can give you an
Yeah, that's a
opportunity
good thing.
to talk. Any questions so far in the first section? Didn't hear? None at this time.
None at this time, Dr. Moxie.
Okay, awesome. Well, not awesome.
No, I feel as though it's pretty straightforward, to be honest.
Sorry, didn't hear?
I feel as though it's pretty straightforward, to be honest. Very informative.
Yes, very informed, most definitely. Okay, so we've laid the foundation. Okay, Nurse Turnquist.
Okay, so moving along.
Mhm.
So at the antenatal services consist of well, the definition refers to regular routine checkups recommended before and during pregnancy. Okay. The goals are to minimize the risk to the mom and baby, to prevent problems from occurring, detect early problems, provide safe delivery for mom and baby, very important. So during the visit itself, you have the nurse and the physician taking history from the patient. Then they perform the physical exam, and they recommend whatever treatment is needed by the patient. Okay. Additionally, they order routine lab investigations such as the urine, blood screening for STIs. Well, first of all, pregnancy tests. So you need to know whether or not that patient's pregnant or not, because a lot of people may have pseudo pregnancies. Okay, so before you want to sign your name to antenatal, you want to make sure that if that's in question, Do that ACG testing, okay? Also add that antenatal visit, health education, and then you may want to refer the patient on. Maybe the patient came in late pregnancy, so you may need certain referrals for that patient. And then education about breastfeeding and parent craft. Okay, so these are another subset of the maternal child health program, the parent craft program. The vision of that is to enlist expectant parents, both mothers, fathers, and they may have other children in the parenting classes. Now, you know, parenting is a problem, well, in a large proportion of our society. So the mission of this is to educate prospective moms and fathers, as well as parents, about the pregnancy, labor, and delivery. There's something like, I think in the US, they call them Lamaze classes, okay? And how to care for themselves and their children to promote the health and well-being of all children and parents in the Bahamas. Now, Lamaze, I think, mostly focus on the labor and delivery, but the parenting program does more of that, how to care for yourself while you're pregnant and after you've had the baby, okay? Some of the topics are importance of antenatal care, sexually transmitted infections, okay? Let's say your partner is positive, you are positive in, let's say for syphilis, you wanna make sure that your partner is treated. Other than that, you get reinfected and the baby is at risk, okay? Body changes during pregnancy, nutrition, health behaviors, labor and delivery, we said that. Postnatal and family planning. Baby topics, some of the most common are general care, how to, let's say, feeding, child development, okay, for the first-time mothers. Now we move on to the postnatal home care services. We spoke a little briefly about that in the past, but once a mother delivers from maternity ward, there is a national postnatal home care service. All right, that service act, that is an actual program, okay, where a group of midwives are charged with seeing those patients within the first 10 days after having a baby. So every day of the year, a midwife goes on maternity ward to collect information of all the births that happened within the last 24 hours. So this, the postnatal nurses and that book on maternity ward, these are the foundations for the national birth lists. Okay, so when you see the birth rate is XYZ, these are the areas where they come from. You say, but how do they get that? People are taking data daily, okay, on your patients. All right, so the postnatal care refers to the regular routine checkups for recommended post-delivery, that is from birth to 6 weeks. So that's the postnatal period. The home visits by the nursing midwife and not the registered nurse. A midwife does it, okay? So from birth till about 10 days, postpartum. Postnatal clinic visit is within 4 weeks. It used to be 6 weeks, but it has decreased to 4 weeks, and that is to pick up things, reduce morbidity and mortality rates among this grouping of patients. So what happens during the postnatal checkup? So in the home, And at the clinic, you have history taken. The nurse takes history of everything's okay with you. How was your delivery? This, that, the next thing. And then physical examination is done, and she moves forward to make any kind of referrals that's needed. Let's say she may find a social issue. Let's say mommy don't even have uh, baby clothes for the baby, or whatever social things that, or she may find some suspicious behavior in the home. You may find other children maybe malnourished, people smoking, all kind of, in some homes that I've been in, there was high odor of drugs, so you may pick up certain things that you may have to refer the patient on, maybe to social services for assistance. Okay, or even to physician for help. Okay, at the at the clinic postnatal checkup, the physician orders routine lab investigations, such as the pap smears done postnatally, screenings for SCI, and hematology values, okay? Because the person has just been through a lot of blood loss, so you want to check to see if those things are in order. Okay, and the routine, there are routine drug treatments like the vitamins you give them. Some persons may need antibiotics based on whether or not they've had sutures from an episiotomy, things like that. And family planning, definitely a part of the prescription. All right. Now, there are different types of family planning, and then some people may choose that, hey, I'm going to abstain, okay, or I'm going to be using condoms, okay. So you have to be well informed of new and current types of family planning methods in order to prescribe for your patients. So that's another part of evidence-based practice. You need to keep up to date with what's happening, what's your new types of products that are used, and the appropriate one for your patient. Even though it might be new and fashionable, it may not be appropriate for your patient. Let's say your patient is elderly, or have some blood clotting issues, okay? You may not want to order the OCP, things like that. So you want to be up to date with your evidence-based practices.
Sorry, quickly before you go on a practical note, can you go back to the previous slide? How do you actually do these things in a home visit? Or, okay, let's go to the top. History taking, physical exam. This is at home, or the physical is also at the clinic? The postnatal.
Okay, good.
I mean, say you're looking to check an episiotomy or the breast, for mastitis or lactation, nipple, what you call it, inversion, and where do you actually do that? It must be gone.
Oh, you mean, okay, in the home.
You said you examine the lady at home, the new mother. Right. So you actually do in the privacy of their bedroom, of course.
In their bedroom, right.
Okay, that's okay. Well, I see now. So you check the breast, you check the episiotomy if they have one. You do it to that detail.
It's right. It's supposed to be a head to toe.
Okay.
Right, because you may miss something if you just do look in the eyes and then go to the breast and then the abdomen, and you miss and
because you have retained products, that's more for the miscarriage. So you ever had any placental what you call that, components left or well, no, you all check the
Retain
placenta.
products of conception. Yes.
No, but that's earlier on though. That's more for the first trimester, not so much way down at delivery.
No,
You can
Dr.
still have it.
Moxie. Yes, you can have retained products of conception if the placenta was incomplete.
Yeah.
Right. So you may have little pieces left, okay, or maybe the physician may have, or the midwife may have problems taking it out. It may have been delayed, and when they examined it, it was ragged. Okay, so you look for keywords in the details of the delivery. And remember what I said was when the nurses, the midwives go on the maternity ward every day, there is a standard form that they fill in. And on this form, I wish I had a form on here. On this form, there's details of the delivery. Okay, so there's a rationale for the type of delivery. Let's say the person had a cesarean section. So the rationale may have been post dates, it may have been fetal distress, things like that, okay? And it will tell you whether or not the placenta was ragged or whether it was complete, okay? It will also tell you about the blood loss, all right? Because sometimes you have people losing up to 800, 1200. So somebody with 1200 mils of blood loss, you obviously know, you have to make sure that they get their medications, and you have to, well, you're supposed to be doing your head-to-toe examination, okay? Examining from the eyes, goes from the head, really. Particularly, you're going to be looking for signs of anemia, severe anemia.
Okay.
Things like that. But the nurse in the home don't do laboratory investigation. Okay, even though I see on this slide it's beside the postnatal home visit. No. Okay. But
obviously
that was the reason for your question, right? And
yes, that's what I was wondering.
We don't do
right.
That happens at the clinic.
Okay, that needs to drop down to the clinic.
Yeah, that needs to be dropped down from there. So I see why you were getting a little agitated there.
Yeah, I can understand. If you're doing, well, I know you're not doing the labs at home, but were you drawing the blood and the pap smear? That's what made me curious.
Oh, no. These weren't intended to be simultaneously.
Okay.
Next to
not read across. Okay, I understand. Okay, you could misread.
No, nursing. We have a.
Oh, I see what's happening. Postnatal care is on one side of the slide, and then the routine postnatal check on the other. But you don't go across and read. Okay.
Right. You don't go across. Right.
Yes.
Okay. No, Dr. Moxie. Nursing, we have a scope of practice, and you could be sued for going outside your scope.
Right.
So that's very important to nurses.
And what's for the medical students? What's the role of the doctor in home visiting while we're talking about home care? Because the mom.
Now in postnatal home care, the physicians don't do that.
Okay.
For medical care, let's say maybe after the 10 days, the first 10 days, no. Now, maybe on the islands, if you're on an island where, you're isolated and the midwives tell you that this patient is really bad, things like that, okay? But if that's all, we're in the city where there's access to a hospital, these patients are sent immediately to the hospital, or the ambulance is called, things like that.
Okay.
But no, the physician, as far as postnatal home visit, only the midwives do that.
Okay. Yeah, because students used to go on home visits with the community nurse, but I guess COVID put a stop to that. But that was part of the the program too, we try to get them to go on a home visit to in the community to get a feel of what is done. I guess although it wasn't
home
supposed to
visiting and
later.
start again.
Okay.
Right. So they will be able to do their home visits, Dr. Moxie, but with
Okay.
their
What's in a typical home visit in case they don't actually get to do it? Because they only have 2 more weeks. Apart from this.
well, we're still in the pandemic, so they will be wearing PPEs.
Oh.
Yeah.
What types of things people visit, like to check pressures, diabetes?
Medical issues are like elderly,
stroke patients,
like people who are homebound. Okay.
Yeah, okay,
So you're
right.
not going to see the average person who have hypertension
No.
at home. So people who are homebound, such as the disabled, the elderly, okay, or people with chronic diseases that have caused them to be disabled. Well, I already said that. Okay.
Yeah.
So let's say you're going to see persons over, well, they say 65, but I guess you need to make that assessment. If the person is ambulant, they can come to the clinic. So let's say you have an 85-year-old person who is not mobile, okay, diabetic, or had a leg amputated, anything that will cause disability. So let's say they want to go in to do the home visit. The first thing that they would need to be aware of is the PPEs. All right. So you need to protect yourself first. All right. The risk for cross infection. All right. And then you would need to keep that in mind when you're using your instruments, your blood pressure machine. There's a technique that they teach you. It's called a bag technique. Once you go into the home, you have to rest your bag on additional paper barrier. Nurses will show you how to do that. Other than that, you don't just rest your bag on people's chair, table, wherever. Okay, you need to rest it on a barrier. That's going to reduce cross infection. So you have to be aware of that. That is very important. You have to protect yourself first. All right. And washing your hands, you may want to use like hand sanitizer, carry that for, which is highly effective. Okay. And in your bag, you would have all of your tools needed for the visit. Okay. So you'd have your blood pressure machine, your thermometer, your stethoscope, maybe a tuning fork based on the history of the patient. So before you go to the home, you're going to look at those notes and see or estimate what you're going to need for the visit, because you don't want to go on a visit and say, oh my God, this patient may have some neurological deficits and I didn't bring my tuning fork. Okay, so which means you may have to plan another visit. So you have to plan for your visit before you go, and it reduces your workload. Okay, so read your notes carefully and see what has happened in the past to that patient, and the diagnosis and your treatment plan, basically what you want to carry for that patient. So once you're in there and your what did they say? Antisepsis technique is in place. You're careful, you wash your hands, you make sure that you are protected. You make your greetings with your patient. You explain the reason for your visit, okay? Because these are humans you're dealing with. Other than that, next time when you come, it may not be so amenable. So you have to explain yourself and explain every aspect of your examination. And you have to ask permission of the patient too before you touch the patient. You don't just go and say, open your blouse or open your whatever. I'm going to do this. So the social side of the patient needs to be respected, and the privacy of the patient needs to be respected. So once that is out of the way, then you go ahead and you ask, you do your history taking, okay? I said it backwards. You do your history taking first, and then you do your physical examination, okay, with permission. And once that has happened and you see you've come up with your tentative diagnosis, if the patient is serious, don't hesitate to call the ambulance, okay? If they're not so serious, and it's just a matter of follow-up, you give whatever education that you need, and you inform them of when you to come back, when you expected to come back, so that they'll be looking for. And guess what they do? Oh, in the Bahamas, patients worship physicians. So, so what you're saying needs to be it needs to be evidence-based, okay? So whatever advice you give that patient, they are going to take that as gospel, okay? So it is very important that, you know, you're well educated about what is it that you're going to say to the patient in order to affect change and improvement in their health status. Okay, and then once you finish everything, you just leave, because I'm sure you will have a caseload of patients to see within that day. And physicians do see at the public clinics, you do have a roster, okay, to see the patients. So the home visiting roster includes nurses see the patients more often. Let's say the nurses see the patient once a month. The physician might see the patient once every 3 months, okay? Or more frequently based on whatever needs that patient has. Let's say patient have a huge bed also, okay? The physician may need to go in once a week to see if any improvement, not that quickly, maybe 2 weeks or once a month to see how everything's going. So it's a matter of follow-up and supervision of what the nurse is doing, and to give your input as to the patient care. It's a teamwork, just like the beginning when I spoke about, or Dr. Moxley spoke about nurses and himself waking and asking emergency. It is a teamwork, all right? Because in anything you do, especially in this healthcare field, nurses are the highest number of healthcare workers. So the chances of you working with a nurse is going to be much higher than you working, let's say, with a lab technician or someone else. So that teamwork is very important.
Excellent. So students, that's the feel of the reality. Okay. It's just for them to go, to actually get the experience. That's what we need to focus on, for next time, I guess.
Oh, so they wouldn't get the
I'm not sure if we could still pull it off, because you need the PPE still on the 13 students.
Oh.
Can it be arranged? I don't know. I mean, you need to, because we'd have to go out with a nurse. That's one student per nurse, eh?
Yes.
We'd have to have 13 different home visits planned.
But 13 visits is not a lot. What you should do, Dr. Moxley, is contact the nurse in charge of the major clinics, the polyclinics like Flamingo, they have a lot. Fleming Street, they have a lot. So based on the area, let's say of the students, let's say the area where they live, if they live in the South, you could send some to Flamingo Clinic. If they live in the East, you could send some to Elizabeth Estates. And if they live centrally, some to Fleming Street, because South Beach, I don't know if they're doing home visiting, because they only say an ambulatory patient. Yeah, I would think they're still doing it. So, but South Beach, they're still doing COVID testing.
Oh, yes. Okay.
So, right, I don't think you want to expose your students. Well, at this
Yeah.
point. Right.
Right.
So,
I understand. Yes.
right.
But thanks for the awesome advice,
Right.
and guidance on this. Right.
Okay. So, let's move on. The other subset of the MCH program is the oh boy, what is this? The family planning policy. Family planning, right, is a big part of maternal and child health services. I think I mentioned this before with the postnatal care. You as a physician, you have to be knowledgeable of the types or methods of family planning. And here, this slide is saying that there is an actual family planning policy for the Bahamas. Okay, so this is basically what it says. The Ministry of Health's National Family Planning Policy is included as a priority goal within the country's overall health policy. So this is also under the World Health Organization. You have to have these systems in place. Okay, so the family planning policy objectives include reduction in the rate of unplanned and unwanted pregnancies, reduction in the number of adolescent pregnancies, very important. That's a key area. So you want to reduce those teenagers having babies. You want to reduce the incidence of illness and death due to reproductive health disorders. Empowerment of both male and females to exercise reproductive rights and take responsibility for their sexual and reproductive health. Okay. Reproductive health is a state of complete physical, mental, and social well-being, not only the absence of disease or infirmity, relating to all aspects of the reproductive system. Now, we heard that before with the definition of health. So this now is reproduction health. So it's relating to the reproductive system. So our related services that are connected to the National Family Planning Policy is, well, our cancer screenings, pap smears and breast exams, counseling, STI screenings, very important. And that's one of the reasons why we work with the let's say, prevention of mother to child transmission of HIV and syphilis. Family planning workshops and contraceptive methods. Okay, so you may find yourself as young physicians participating in some of the cancer screenings on at some of the major clinics and even in the family islands. Okay, we also partner with civic organizations who sponsor certain events, let's say for the Male Health Initiative, or even they sponsor cancer screenings at some of the clinics on the family islands. Okay, I myself personally have participated in some of those screenings. We did some pap smears. Okay, as a midwife, you're able to do that. And breast exams. Okay, so we did those. Counseling also. Okay, but you know, as nurses, we can't initiate family planning. All right, it has to be initiated by a physician. We could continue it. And that is why at the regular clinics, at the government clinics, you have family planning clinics. All right. At that clinic, you may have one physician who is there to for consultation and to initiate, for new people, to initiate that family planning methods. And then you have most of the staff there are midwives or registered nurses who continue the methods. Okay, most of the prescriptions are like, let's say for the OCPs, you may have like 3 months. We give like microgynon for like 3 months, or a new trend. You may have the subdermal implants, which last for 5 years. So that cuts down on the amount of follow-up clinics that patient does. Obviously, when they first get it in, you would need more frequent follow-ups to make sure that the area is not infected. You know, there are no problems, no issues with that. Okay. And of course, sometimes you may have the patient coming back and say, I want to get pregnant again, so I need this taken out. So all of those issues are involved in your family planning clinic. Any questions on that, on family planning? Before I go to male health, the maternal and child health unit, we are the central point for the supplies of most of the family planning products, such as the tablets, the microgynon, the implants, okay, the IUDs, the intrauterine contraceptive device. You need to, well, your nurse in charge orders it from the maternal and child health unit. So we are more like the suppliers for that. So we keep a monitor on those. Also, we supply the clinics with fetal monitors, the Dopplers, the portable ones, the tiny ones that you use during antenatal clinics. We supply those to the clinics, and pregnancy tests. We're responsible for that. Okay, so that patients, there's accountability too on the clinic side. They need to report. There's a slip submitted every month of names, line listing. So we don't really want numbers. We want line listing of actual patients that receive the information or the products. So we're the hub for that. So moving on to the Male Health Initiative, this is an area that you'll get more information on. I think Mr. Finley is doing that at 4 p.m. He'll go more into detail, but this is just a quick overview of that. Now, you know, in maternal and child health, in order for a lady to have a baby, she must have had intercourse with a man, okay? Now, or in today's term, if you're doing some other type of, let's say IVF or something, but you still need the male sperm in order to do it. So men are key players in the health and wealth of the mother and the baby. Okay, so the Male Health Initiative is very important to this program. Okay, so it is a component of the maternal and child health program. The vision of it is for all males are made aware of their role in the family health and given access to reproductive health services. So what are the objectives of the Male Health Initiative? Okay, there are 6 major objectives. Okay, We want to promote abstinence and delaying sexual activities to fight STIs in younger males. So those teenagers and even children, you know, because you've heard horror stories, okay? So we want to bring that awareness to young people about abstinence. We want to educate young men about their sexual and social obligations. We want to encourage planned families with active parents. And we want to promote male sexually transmitted infection education, prevention, and treatment. We also want to use civic organizations, very important, to this program. All right. So our overall initiative is to train church people. Okay, those pastors, those counselors at the church, very important, because why we target the church? Because these are people with morals. Well, assumed that, you know, they will teach high morals to our young people and give them guidance. All right. Social and health workers to reach men and the male psyche. All right. So you want trusted people, though. You don't want to get, you know, people who are not vetted. So these people are vetted in order to allow them to approach young, vulnerable people. This is a vulnerable population. Okay. So you want to also increase men's reproductive health knowledge through the media. All right, which, like Dr. Moxie said in the past, you haven't heard hardly anything about male health in the media. So that is something, because of COVID, though, and attrition of staff in this male health program. You know, we've had persons retired years ago. I think they have had almost 100%, almost 90% of the staff in the male health program was retired. Okay, so the succession planning for this initiative is highly needed in order for the continuation, you know, and training, ongoing training of people. So that's an area that needs attention with succession planning. All right. And like Dr. Moxie say, PSAs. So we want to do public service announcements to bring out the message more, to you know, letting people know that, hey, there is access to healthcare, there is help. There are people who are concerned about you. Okay, so very important there. The young man who is going to give you the presentation later this evening, he is a registered nurse and who is very much interested in male health initiative, Mr. Finley. So maternal morbidity. So we dealt all of that was the preventive side. Let me see my time. I think I have about 20 minutes or less, but we'll soon be finished. So we're on the sickness side of maternal health, because it's a reality. Okay, when you think about maternity ward, you think about, oh, somebody is sick, even though pregnancy doesn't mean illness, but it is a condition where things could go wrong. Okay, so these are the top leading causes of antenatal referral to hospital. These are from the urban clinics, right? In New Providence, preeclampsia, hypertension. It looks like hypertension is kind of top causes. post dates, people go over their dates, severe anemia, very important. That's a good area for research. A lot of pregnant women with low HBs, 10 or below, you will find the incidence of that is prevalent. So that's an area for research there. The reasons why, factors that contribute to this, whether it's nutrition, whether it's physical from heavy periods or what. So that needs to be investigated. Induction of labor, and well, that goes back to post dates or maybe hypertension or diabetes, whatever NCD might be related to why the physician need to induce labor early. Diabetes mellitus, premature labor. Now, all these things bring red flags because why are you having premature labor? Okay, these are other areas for research also. You may want to look at STIs. Some people, let's say with chlamydia or any other STI, you may be more at risk for going into premature labor. Okay, so reasons for those, these are good areas for research. Hyperemesis gravidarum is another area for that causes people to go into the hospital. Polyhydramnios, hemorrhaging, well, which is related to the prem labor. Maternal mortality. Okay, World Health Organization gives an overall definition of maternal mortality, which is the death of a woman while pregnant or within 42 days of the termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy, but not from accidental or incidental causes. Now, the maternal mortality is subdivided into two spots. This here is the early one that I just spoke about, the 42 days. Within 42 days, you would call that early, and then you have the late, okay? More than 43 days, but less than 1 year after the termination of the pregnancy, okay? So you may have, you may say, well, that was another baby long ago. How is that a maternal death? It's because it's the international definition for the maternal death, okay? And also too, irrespective of, it says here, pregnancy-related deaths while pregnant or within 40 days of termination, irrespective of the cause. So let's say, for instance, you have somebody with COVID, you say, oh, that's not related to the pregnancy. So irrespective of the cause, okay? So here's what the World Health Organization and the United Nations speaks about maternal mortality. More specifically, the Sustainable Development Goals. I'm sure you've heard it before. Governments have agreed to accelerate the reduction of maternal mortality by 2030, okay? More so, we focus on Sustainable Development Goal 3, sets an ambitious objective of lowering the worldwide maternal mortality rate to less than 70 per 100,000 births, with no nation exceeding twice the global average. So these are most of the leading causes of maternal deaths. Eclampsia, which results from hypertension. Complications of pre-existing conditions such as sickle cell anemia, congestive heart failure, HIV. So I see hypertension recurring in there too. postpartum hemorrhage, ruptured ectopic pregnancy, complications following abortion. Also, I want to put in there COVID, which is new. So maternal mortality from complications of pregnancy, childbirth, and puerperium. Similar to what we said. These are just some of the statistics. Now, this is up to 2014. Beyond that, they are in process, and I cannot give you those numbers until they are official. But these are basically a trend from 2000 to 2014. So if we look on a trend here, in 2000, the numbers were very low. It was 2, 2005, and 2010, there was an elevation to 5, and 2014, it went back down again. But of course, you know, we are in the pandemic, and so those numbers were increased because of the COVID. Okay, so those are your trends for maternal health. Before I move on to child health, any question? Almost done, and everybody's tired now, including me. Okay, child health. So we're going to look quickly at the wellness first, and then we'll look at the child morbidity. So child wellness is attached to Goal 3 of the 2030 Agenda for Sustainable Development Goals of the United Nations. Okay, and this also the Bahamas has signed on. So these are, we are charged with maintaining these strategies. So in primary care, you have these are objectives. We want to promote holistic, that is physical, cognitive, emotional, and social health and well-being of children. And the core components at the clinic level are the well child clinic, sick child clinic, and immunization. So you may have heard of those names for the clinic. Okay, immunization is usually held under the well child clinic. Okay, so if you, when you pass a clinic, you see on the bulletin board or the the board outside of the clinic, which says the clinic services, you will see well child, sick child, general clinic, or whatever clinics that are antenatal, postnatal clinic those days and time. Okay, so that's the categorization of the clinic for children. Okay, so what happens in the well child clinic? The nurses and physicians assess physical growth and development. Okay, educate patients. Now, why I say nursing and physicians, because at some clinics, let's say particularly on the family islands, there are no doctors. Okay, so nursing, nurses are well trained, and in this area, the minimum qualifications for a registered nurse is at the bachelor's level. Okay, and physical examination is taught at the bachelor's level. So the nurse is highly competent to perform the physical examination, the head to toe physical examination. Okay, and she's able to recognize any, well, most of the red flags. And she, well, her scope should be known whereby she's able to refer on to the physician. Whether that is the patient may have to go into Nassau, or whenever the visiting physician comes. On some islands, the visiting physician may come once a week or once a month or on call. Okay, they might be on a mainland. Let's say, I know in the island of San Salvador, the physician is on the, the physician for Rum Key is on San Salvador. So if you were a nurse on Rum Key and you had a issue with a child, you would have to call the doctor over at San Salvador. So who will give you advice as to what to do? Okay. And if the condition warrants where the child could wait until when the doctor comes, maybe on Friday or whatever day, then it happens like that. So in some cases, the nurse does the physical assessment of the child. Okay. Education, of course, you would need to do that. Immunization is also done. Okay, so there's a standard age range for routine physicals in the well child clinics, and these are the schedule for the Bahamas. You have 1 month, 2 months, 4 months, 6 months, 9 months, 12 months, 15 months, and these are in line with our immunization schedule. So this schedule may vary by country based on their health schedules. Okay, so their health agenda. But in the Bahamas, this is basically what we do. And I think I have a immunization schedule here, right? So at 2 months, we do the first basic vaccine type. You have the DPT, the Hib, the hepatitis B, polio, the pneumococcal, and the rotavirus. And the same thing is repeated for 4 months and 6 months. And at 1 year, the child gets the first MMR and the varicella. 15 months, you get the booster, you get the first booster of those that you received earlier. Okay. And in particular, DPT, Hib, and pneumococcal, and you get the second MMR at that time. At 4 to 5 years, you have the second booster given. And the boosters are of what has been given before. And at 10 to 12 years, they have introduced the HPV, okay, to girls and boys, okay, but they must be within those age range, okay. Now in the Bahamas, immunization is not given without the physician's acknowledgement. So this is something that the physician has to assess and order the immunizations. So the nurses at every time, once the patient comes back, they have to see the physician for each one of those. And there was something else I was supposed to say about this immunization. Okay. All right, we'll come back to that. Right, there was another important issue I need to bring up with that, but it'll come back. So breastfeeding and lactation management. This is another area that is covered under the maternal child health unit. I know you've heard all over the world, or even in your schooling at university, breastfeeding. Okay, this is a national initiative, and it's also a part of the Sustainable Development Goals. It has to do with infant nutrition, children nutrition. Okay, so you want to reduce that that poverty. You want to reduce, you want to increase their health status with good nutrition, and you want to ensure that as much mothers as possible, exclusively breastfeeding where it is possible, because breastfeeding is contraindicated in the Bahamas for certain conditions. Okay, so that is why breastfeeding is an entire program under the lactation management and MCH program. Okay, so the vision is the Bahamas has all mothers enabled to practice breastfeeding exclusively for at least 6 months. That is where possible. 6 months is the rule. The mission is to assist clients in practicing successful and sustained breastfeeding through health education and promotion efforts. And you want to teach all expectant mothers. So in the antenatal period, you need to teach, you want to teach them how to successfully breastfeed and keep this up for at least 2 years. You want to train all your staff, including your physicians, in breastfeeding. So other staff members that you may not think may need the training in breastfeeding are people like your housekeeping staff. Why? Because these are the people who you see every day. Okay, even in your classroom, you may see somebody come and say, "Excuse me, I want to take the garbage out." Okay, or "I want to clean your desk." Okay, these are the people who come in contact with patients, and that's where patients ask them certain questions. "Oh, do you think this is right? Oh, do you think I should be doing this?" So you want to have that, all levels of people who come in contact with patients. Even they take the message home. Okay, so that level of training is very important. And you want to heighten the community awareness of importance of breastfeeding. I know you may have heard or watched on the news where they're doing little campaigns about breastfeeding. That's very important to bring community awareness. The other day, we just did a walkathon by walking through we walked through Augusta Street, okay? A highly populated area, okay? But we just took the message. There was a banner. We talked to people on the side of the streets. "Oh, we're supporting breastfeeding," things like that. So it's just an awareness that you want to bring to the community about it in order to promote it. Okay, so all those are other good stuff about the breastfeeding initiative. Baby-friendly hospital initiative. Now,
sorry, just one point. Nurse Carlotta class. Her role, I just want to reflect on her role way back. She was a total champion for breastfeeding. I don't know if you'll ever have anybody like her again. But it's good for the students to know. I was telling them just what you said, how sometimes programs have a cycle and they flourish when there's somebody who's passionate about the area. And then when that person retires, it just seems to not fizzle out, but less.
Yes, we must
focus is placed on the program because that passionate driving force isn't there anymore. And I've seen it, because breastfeeding was taken. We actually had a concert at Government House. I remember that clearly. She took it, to the max. She was so keen on the area, so as a historical note,
I agree with you, Dr.
We had these champions
Nurse
of these programs.
class. She's in her 80s now. So but she has, guess what? She was on that walkathon a few weeks ago.
There you go. I didn't have a clue, but she still loves the area,
She still is enthralled about breastfeeding. But we have a president of the National Breastfeeding Association, Nurse Hall, Tranika Hall. Now you may hear that name buzz around. Tranika Hall is just as passionate
Okay.
about
Awesome.
breastfeeding
Yeah.
as Mrs. Carlotta
That-
Class.
That's her
Right?
granddaughter in breastfeeding. she, she was a pioneer, you know. So when you're writing the history, you have to put her,
Yes.
give her a
Yes.
proper honor, you know, as the pioneer.
Yeah, Miss Carlotta Class, it started out with them attending a workshop, I think in Barbados, on breastfeeding, and she was so impressed with this
The benefits
initiative
of breastfeeding.
that
It's so positive.
right, she
Yeah.
brought that back here, and
Yeah.
it was just a go from there.
Mm-hmm.
So yeah, she is one of the pioneers of the breastfeeding initiative for
Right.
the Bahamas. Now,
Well,
currently, we are working on the breastfeeding policy, because guess what? All those years we didn't have a policy.
yes.
A national breastfeeding policy. And
Right.
this baby-friendly hospital initiative is one of the designation you get, international designation you get once you have a national policy. Okay, so the policy, though, it's like a process. It's an evidence-based process that involves a dray load of people. You have mostly stakeholders. You have government officials. You have other government agencies like education, the preschool, anybody who deals with mothers, babies, okay? Then you have the non-governmental agencies, you have the civic organizations, you have the, let's say the Breastfeeding Association. And now I was contacted by one of the physician associations. They have a focus now on breastfeeding, on advocating for workspaces for physician mothers who, so they everyone want to bring attention to breastfeeding. So this process here, with the policy and the breastfeeding hospital initiative is highly welcomed. Okay, and this brings into play this is a serious designation. It's very prestigious designation. Okay, however, we are still employing the how do you say it, the tenets of the baby friendly hospital initiative, which is no bottles policy at the maternity ward. So when you go to a maternity ward, even the physicians will tell you, oh, breastfeed, you better breastfeed that baby because we're not giving any bottles. Okay, so based on the health of the mother and the infant, they would be advised to breastfeed on the ward. If parents refuse or in instances where breastfeeding may be contraindicated, alternatives are offered. And you have the infant formula. Okay, so that's just a note to say all mothers and babies at the public hospitals are encouraged to breastfeed. We also have a relationship with the private hospital, Doctors Hospital. They're also on board with this, and other birthing centers. I think there are 1 or 2 birthing centers and private birthing centers. So they are also in collaboration with us on this breastfeeding thing. But that was important what you said, Dr. Moxie, with Miss Glass.
Yeah.
We don't give our own the recognition that they deserve.
Yeah.
You
She was
know,
definitely a champion. And the role of Nurse Ampersand Simonet, like, is sort of coming back. She was sort of in that area too, I think. What was her?
Yes. Husam Simonet, she
Mhm.
used to be the Nurses Association president.
Oh, okay.
Right. However, she was a senior nursing officer on maternity ward for many years. I
Right.
mean, even while I was working at the hospital, and that's like over 20 years ago.
Yeah.
So,
I'm just reflecting back, and it's like, you know, memory came up really strong. I said, I know she was something to do with maternity, maybe even from the time I was an intern. That's probably why I
you're right.
remember.
You're right. Because guess what? She was at the walkathon too. So she's highly active in
Yeah,
the association, the
yeah.
breastfeeding association.
They're keen. I know they love that area.
Right. So she's in retirement herself, and Mrs. Clark's, they are in retirement, but they are still giving
Mhm.
assistance and
And support. Yep.
right. I think
Mhm.
they are trying to really, at this stage now in their retirement, I think they are pushing to make sure that we get the policy and this designation, baby friendly hospital initiative.
Yeah. Mhm.
Right. I think they will they will relax a bit once
Yeah.
once this
Once that happens. Yeah. Yeah.
right. Okay, which is
Or-
a tremendous accomplishment. So
Right.
um
It's
you know,
like the realization of their hopes and aspirations, for their program that they put
you can imagine
so
from
much
from
into.
from about 20 years ago, I remember working at
Mhm.
the hospital where they were having these baby friendly initiative meetings at the chapel, and wow, you
And
know,
still, yeah,
and
drags on.
still, you know,
Yeah, that happens in health. It drags on. There's so many competing priorities.
oh dear.
That's another, concept students have to get, that sometimes you have to decide, not sometimes, you have to decide. It's called priority setting, and you decide, okay,
Right.
diabetes is gonna come ahead of something, and we have these resources, human, financial, and the planning, you do that. So, and then
Yes.
sometimes you just don't have the people to write the policy. I mean, that's where power comes in. Because really, if we wanted it done, we should have brought in a lactation technical
Consultant. Yes.
consultant for a year or 6 months, whatever was needed to do it, and get it done. Because we may not have the resources in country, but we certainly can go to the sub region, or
Yes. Yes.
get the person to come and help us if we don't have it, here already. So
Very good point, because the persons who the stakeholders who are charged with these initiatives are also involved in other initiatives, like you said, because now we are working simultaneously on, you have the adolescent health policy, you have the prevention of mother to child transmission of syphilis, which is almost, I think that has trumped everything right now.
yep.
We're trying to get the country what they call it, elimination free, well, virtually free. You wouldn't necessarily have a zero amount of patients, but literally, it's what they call it, eliminated. You have eliminated this from your country, and some small island states in the Caribbean have done it. So imagine that.
Yeah,
Places like Cayman Island, Montserrat, but these are people with small countries with very small populations. Okay,
yeah.
Dominica is the latest. But the largest country that I know of is Cuba. Cuba was the first, they said, in this part of the Americas who eliminated syphilis from their country. So, yeah, so we
So those,
So you have a lot of different initiatives working simultaneously. So it's a matter of like you say, priority and bringing in help. I like that what you said. The consultants, that's the purpose of a team. All right.
Yes.
We are not all in one.
Yeah.
So we should be operating like team members.
Yes.
Okay, let me wrap up. Sick child clinic. Have you seen nurse Fiona Sinalbot? Is she on the call?
Yeah, she joined
At 11
maybe
a.m.
about half an hour ago, I think.
Okay, all right.
Yeah,
So oh, you're here. Okay, sorry to run over my time. I'll soon be finished. Sick child clinic, very important part of our clinics. So basically, the same thing happens during the sick child clinic as the well child. You want to assess the health status. You want to diagnose the illness. However, the urgency is greater because you have you have the risk of causing harm to the child or causing the child to improve faster. Okay, so you want to assess their health status as quickly as possible, diagnose the illness, treat the condition as soon as possible, and provide health education to prevent a repeat of what has happened in the past. And you want to refer on to any specialty clinic, social services, any agency that may help, whatever the situation is. And these are some of the most common causes of referral of the children to the hospital. As in most conditions, you have upper respiratory tract infections trumping everything else, okay, for children. Air diseases, gastroenteritis, ringworms, eye disease, thrush, scabies, skin infections. And then you have this issue with the infant mortality. That's just a definition, the number of deaths in children under 1 year of age for a given country or territory. It's expressed as numbers of deaths as reported from the National Health Authority. So reducing infant mortality rates is also a sustainable development goal. Very important, okay? And all of those good things that we spoke about wellness of children, these are objectives in reducing the infant mortality rate. Okay, and that's just a definition of the what infant mortality rate means. Here is a trend of live births and infant deaths, a comparison over what this is almost 20 years, from 94 to 2019. Okay, so the lighter green is live births and the emerald green is the infant deaths. Okay, leading causes of infant deaths. In the neonatal period, you have short gestation period, prematurity, very big, low birth weight. During the birth, you may have meconium aspiration. That's a common cause when you'll go to special care baby unit. Congenital abnormalities, respiratory infections, respiratory infections and asphyxia during birth. Okay, that's a common cause for infant deaths. let's say you have a prolonged labor that may cause fetal distress. And this is just leading causes of child. What's a continuation of child death from the end of the first month to 5 years of age. Pneumonia, diarrheal disease, birth defects, and malnutrition. Malnutrition, we don't see that too much in the Bahamas, but it do exist. And the maternal and child health, we do monitor child weight. There is a form where that is submitted every month to the unit. So statistical department, they have a record of that and it's monitored. The school health program, very quickly, you're going to get something on that later. But basically, we look after child and adolescents, their healthcare while they're in schools. In the preschools, they don't, right for now, school health program doesn't cover the preschools, but from primary school to high school. The medicals are not done. In years gone by, they used to be done at the school themselves. I personally, as a nurse practitioner, I did a lot of senior medicals. I did the senior children in grade 10, and we had a physician, Dr. Quilling. She did the grades 1 and 6. So she did the pediatric physicals at the schools themselves. So there were thousands of children that we saw within that school year. And soon after I left, I think it continued on for about one more school year after that, because they sent in a doctor and the doctor didn't stay. And so eventually the school health, the physical program went to they sub it out to the clinics, and it's history from there. So now all children have to go to the clinics at this time. So at this time, the clinics are very busy with mothers trying to get their children with their physicals as a requirement to enter schools. Okay. And that is a mandate by the Ministry of Health, because you want to stop, you want to pick up early any potential problems with children coming into school. Their entry levels are grade 1. Okay, so that'll be an entry level, especially for people coming out from outside the country, like immigrants and general population. Grade 6 is when they're actually leaving that school and they're entering a new school, grade 7. All right, so you want to do that physical in grade 6 and grade 10. Okay, that's like midway before they really graduate and they get into adulthood. Okay, so that is there. And then SCAN program, which Nurse Albert will expand upon quickly. I will just say they are to provide a coordinated approach to managing and support children suspected to have been abused by providing access to complete health care. Okay, and they provide medical, psychological, legal services, well, in collaboration with these agencies. So Nurse Albert will tell you quickly, not quickly, she will tell you more in detail what exactly those services are. And they keep current statistics on Princess Margaret Hospital children. Okay, so children who are admitted to the hospital because of suspected child abuse and neglect. So follow-up is there. They survey child abuse knowledge, attitudes, and practices. And child care providers should get regular abuse training. Education is also a big part of them. Okay, so she will bring you more information about their community education and their direct one-on-one education sessions with parents. So in summary, we provided a general overview of the maternal and child health program on the Bahamas. We outlined goals and objectives of the program. We reviewed key maternal and child health indicators and trends. We reviewed child health indicators and trends. And we went through all of the subsets of the program.